My biggest challenge is determining the cause of the flare, right? Is it a viral infection? Is it lag ophthalmos? Is it looking at a screen too much and not blinking as much? Is it contact lens wear? What's contributing to the flare? But the final common pathway is there is a breakdown in the tear film and the protection of the ocular surface, and that breakdown needs to be repaired as soon as possible. The biggest challenge really for me is having the patients understand what we're dealing with, having the patient trust that you're going to help them quickly, and that's one of the hardest things, and then having them manage the dry eye chronically so we reduce the number of flares and we increase the comfortability of the patient's eyes. I wear contact lenses myself. I suffer from dry eyes. Flare-ups are not fun and people want relief. Often patients will rub their eyes or they'll do things that aggravate the flare-up. The flare-up needs to be broken and they need to feel better, and Flarex really is my go-to. It's my topical steroid of choice in order to achieve those goals.
When we have patients with moderate to severe dry eye, they flare, and they can flare frequently, and the biggest challenge there is managing that frustration. Patients feel like, once we start treatment, they're cured, but the key is to explain to them that there is no cure for dry eye. Fortunately though, when they do flare, we tell them that, look, we have medications that can help with that, and a steroid like Flarex is a big part of that treatment.
What's the biggest challenge we face when a patient who has chronic dry eye suffers a flare? Well, the biggest challenge actually is they lose faith in their treatment. We live in a Tylenol society. You have a headache, you take a Tylenol, you feel better, that's it, it's all over. The reality is that dry eye disease doesn't work like that at all. It's a chronic disease that requires chronic attention, and in the perfect setting, the patient no longer realizes that he or she actually has dry eye disease at all. But we've come to learn that even in those people who have chronically well-controlled dry eye, they're still going to get flares. And so our challenge, first and foremost, is to reassure the patient that yes, you're still adequately treated. This is the nature of the beast. The second challenge is helping the patient realize that you need something extra. During those periods of time when you have dry eye disease that's affecting you in a negative way, you need something extra. At that time, we need to make the inflammation that we know is present abate. And so we're going to prescribe a steroid, even in a patient who's been stable for quite some time. We don't want them to lose confidence. We don't want them to abandon their chronic immunomodulator therapy. We want them to feel well, while at the same time giving them concrete support that they have a chronic problem that needs continued chronic care.
What's the biggest challenge when you're treating dry eye patients with a flare with regards to their management? First of all, you have to select a therapy that is less likely to induce complications. Secondly, you don't want to overwhelm them with the therapy because they have many things that they can do, and if you give them too many things to do, it can become overwhelming to the patient. And third, it's the chronicity and severity of the disease that creates a management issue, because patients have a lifelong disease with dry eye syndrome and it requires constant management.